Welcome everyone to this Public Health Agency of Canada COVID-19 foundational webinar. My name is Aleksandra Wierzbowski and I am a project manager at the National Collaborating Center for Infectious Diseases. I will be your moderator today. NCCID is funded by the Public Health Agency of Canada to provide knowledge and evidence for use in public health planning and policy, and is supporting the agency with knowledge translation during the COVID-19 pandemic response. I would like to acknowledge that NCCID is located at the University of Manitoba on original lands of Anishinaabe, Cree, Oji-Cree, Dakota and Dene peoples, and on the homeland of the Métis Nation. Today's webinar will begin with the previously recorded opening remarks from Deputy Chief Public Health Officer, Dr. Howard New. Following his remarks, we will have 3 live presentations, each followed by question and answer period with the experts. There are just few housekeeping items I would like to mention. We are running this webinar through Zoom. If you have technical problems with Zoom, please email us at nccid@umanitoba.ca. For the question and answer session, we will be using the Q&A tab. Please submit your questions for our speakers there. You can like other people's questions to push them up in priority. We will try to answer as many questions as possible, but might not get to all of them. Speakers and hosts will use the chat tab for extra communication to attendees if need be so. Keep an eye on the tab as well. The recording of this webinar and the presentation slides will be available shortly after the webinar at nccid.ca. Now we are ready to begin with the opening remarks from Dr. Howard New.
Hello, I'm Dr. Howard New, Deputy Chief Public Health Officer of Canada. I would like to thank the National Collaborating Center for Infectious Diseases for hosting this webinar, which the Public Health Agency of Canada has created for healthcare providers to support the COVID-19 vaccination rollout. I would also like to thank all of you who have signed on to attend. The purpose of this webinar is to help you understand the processes in place to authorize and create guidance for vaccines in Canada, the importance of the COVID-19 vaccines, and to gain confidence in their safety and efficacy. It will help prepare you to have conversations about COVID-19 vaccines. Among you are practicing and retired physicians and nurses, pharmacists, and other healthcare providers who have volunteered or been assigned to administer COVID-19 vaccines to people across the country. I am grateful for your contribution to the pandemic response. In addition to your role in vaccinating Canadians, you are also a trusted source of vaccine-related information for people in your communities. Information about COVID-19 is continually evolving, and it is normal for people to have questions and concerns. As we prepare to vaccinate more and more people in the coming months, we want to provide everyone in Canada with the facts they need to make informed decisions about vaccination. Public education is critical, and it begins with you. Today's webinar consists of 3 modules. First, Dr. Megan Bettel from Health Canada will lead you through Health Canada's vaccine regulatory pathway. In Module 2, Dr. Shelley Deeks, Vice Chair of the National Advisory Committee on Immunization, or NACI, will explain the role of NACI in developing guidance for use of COVID-19 vaccines. And finally, Dr. April Killikelly and Dr. Marina Salvadori from the Public Health Agency of Canada will talk about the COVID-19 vaccines, including information to address some common questions we receive from Canadians. After each module, there will be between 10 and 20 minutes for our presenters to answer your questions in real time. Thank you once again for your participation. By preparing yourselves to administer the COVID-19 vaccines and arming yourselves with reliable, accurate information, you will be well placed to provide informed recommendations to people who turn to you with questions and seek your advice. Your commitment and work will help save Canadian lives and move Canada towards the end of this pandemic. Thank you.
I thank Dr. New for his opening remarks. Now I would like to invite Director General of COVID-19 Regulatory Response Team at Health Canada, Government of Canada, Dr. Megan Bettel, to give her presentation on Health Canada's COVID-19 vaccine regulatory authorization process. Welcome.
Okay, thank you, Alexandra, and thanks to everyone who could join us today. So if we go to the next slide, please. Just to indicate that I have no particular conflict of interest to declare. And if we go to that slide, yes, so the idea today is I'm just going to walk you through what Health Canada has been doing to speed up our review of COVID-19 vaccines and tell you a little bit more about the process so people can have some more familiarity with how we review vaccines and some confidence in how we're doing that. So if we can go to the next slide, please. So obviously, there are a lot of people involved in bringing vaccines to Canadians. So I'm just going to talk about the first part here, what Health Canada does as the regulator of health products. So our role essentially is to authorize health products for use in Canada. And that's based on evidence of safety, efficacy, and manufacturing quality that's submitted to us and is reviewed so that we can make a decision about whether a product can be sold in Canada. Once authorized, we also have a role in continuing to regulate the safety and the effectiveness of a product after authorization. You'll hear from the next speaker about the role of the National Advisory Committee on Immunization, which makes recommendations for how these authorized vaccines can be implemented into the Canadian healthcare systems. And the Public Health Agency of Canada also has a role which is shared with Health Canada in vaccine safety surveillance, also working with the provinces and territories. Finally, the provinces and territories ultimately determine how their public vaccination programs will be implemented. So kind of how it's rolled out, who the healthcare professionals will be, and what the immunization sites will look like. So it's a complicated system, but we're all working very well together to bring vaccines through to you and to Canadians. Go to the next slide, please. So how does this normally work? In normal times, a vaccine developer, a manufacturer will identify a vaccine candidate. They'll do the basic research, they'll do animal studies, and then bring a product into human studies to test to see if it's an effective. And as they're going through this development process, they'll also be working on their manufacturing processes. In normal times, all of this work is done. And then the manufacturer will bring this data to Health Canada. They'll make a submission for authorization. Health Canada will review it. And for normal drug submissions, it can take up to about 10 months for a review to be completed. That's kind of our normal target. Through the course of the review, we have teams of Health Canada experts who are looking at all of the data that's been provided to us to determine if the vaccine is safe, if it works to prevent disease, to prevent infection, or to prevent the consequences of infection, and if it's manufactured consistently and well. And this is particularly important for biologic products like vaccines, that each batch is made consistently so that we can expect the same performance every time. Go to the next slide, please. So obviously, a multi-year development plan and a year-long review process is not what works for a pandemic situation. So very quickly, when the pandemic started, Health Canada started to develop what we call interim orders. And these are temporary regulatory tools. They've been put in place for a year. And in the case of kind of dealing with drug submissions, we created an interim order which allowed us a lot more flexibility. First, it permitted rolling submissions of data from manufacturers as soon as that information became available. Some more flexible administrative requirements to reduce some of the administrative burden to bring some of these submissions into Health Canada. And then we created a pathway where if requested, a product could actually be pre-positioned. So it could be brought into Canada before it was authorized. It could be distributed out to deployment sites so that a vaccine could be rapidly deployed immediately after authorization if that was a decision taken. So what I want to emphasize through all this process is that we've maintained fairly high standards for the reviews of the vaccines. We still require all of the safety data, the efficacy data, and the quality. So for the authorized COVID vaccines and the ones we currently have review, the full suite of animal studies have been done, and large clinical studies have been required. And these have included randomized, placebo-controlled phase 3 studies, which have included 30 to 40,000 participants in each study. Go to the next slide, please. So what does a rolling submission actually look like? As I said, what we normally do is have all of this research done before we look at it. In the current situation, we have been engaging with vaccine manufacturers really early and allowing them to start bringing their data to us. So for example, if they have their animal studies done, they could submit that data and we can review it right away. And then as the product continues to go through development, as they do their early clinical studies, as they begin to nail down their manufacturing processes, all of that information can continue to flow to us so that we can review it basically in real time. At some point along the process, we've got to the point where we have enough data to make an authorization decision. We're confident that it's safe, it's effective, it's well made. But we often want to follow up a product afterwards. And the interim orders have given us the authorities to put binding terms and conditions on an authorization. This means that we can require manufacturers to continue to submit data to us as their clinical trials continue or as they develop new information about the use of their products. And so we're requiring that ongoing submission of data for some time after the initial authorization. So this is still taking several months to get all of that data into Health Canada and to get it reviewed. And the authorization decision is really based on all of that evidence. Are we confident that the product is safe and it works? Whatever we know about the risks, can they be managed by labeling, by restricting the use in certain populations, or by other measures? Where there are gaps in our knowledge, is there a plan to continue to characterize that product? So for example, are there plans to study a new vaccine in younger children or in older populations or in people in comorbidities or in pregnant women? So what's the plan in place to continue to collect the data on that product? And do we have product labeling that accurately communicates what we know about the safety profile and how the product should be used? Go to the next slide, please. So obviously in a global pandemic, we have to work globally as well. So Health Canada has been working very closely with the entire community of international regulators. So basically every week, all of the major regulators have been getting together to talk about the science of COVID-19 and about the development of vaccines and treatments. In this way, we've been able to align our scientific approaches so that we have general agreement on things like clinical trial endpoints and what each regulator would require for authorization. We're able to share information about the vaccines or products that we have under review, share best practices as we've been adapting our processes to be faster and more nimble, and to really quickly share information on any potential safety issues as they may be emerging. We've also been working on making sure we've got good communication to Canadians and both people who are receiving the vaccines and those who are administering them. One example is how we've begun to post information on what we're seeing in real time as vaccines are rolled out in Canada. So providing information on a dashboard, both about the adverse reactions which have been reported in the context of the number of vaccines that have been administered, so people can have access to that safety information. And should any new safety information emerge, we're making sure that we're communicating to Canadians and to healthcare professionals so they have the most up-to-date information about the products. Next slide, please. So the question that always comes is how long does it take? And every vaccine review is different and has been different so far. A lot of it is very dependent on the manufacturer themselves. What data have they given to Health Canada? How quickly are they responding to our questions? And have they given us enough data so that we are satisfied on the safety, efficacy, and quality? I mentioned some of the Canadian specific information, such as the product monograph, the labels, and other information for healthcare professionals. The pharmacovigilance planning, so giving Health Canada a plan by which a vaccine can continue to be studied and monitored in Canada specifically, is a critical component of making that decision. And then the information on manufacturing is also very important, because as manufacturers are trying to scale up, developing multiple factories so that they can provide a vaccine supply to the world, we need to be able to have all of the manufacturing information we need for the supply that will come to Canada. And so a vaccine that may be shipped to Canada might be manufactured somewhere different than it is than the supply for the US or Europe. So we need to make sure that we have all of that information for the Canadian specific supply chain. Another thing which can affect timelines is really that the vaccine manufacturers are actually trying to get their vaccines approved in multiple jurisdictions. So they also have to have the ability to deal with multiple regulators and respond to all of our questions on time. So it's different, but we are trying to expedite this process as much as possible. Next slide, please. So transparency is really important, and we have already heard Dr. New commenting about supporting confidence in the use of vaccines. And we feel that making a lot of the information about how Health Canada is making decisions is important for supporting that confidence. So when we receive a vaccine submission, we post that right away so people are aware that we have a new one under review. And when we get to the point of authorizing a new vaccine, there's a lot of information we're making available right away. So as well as the product monograph, which is your detailed information on the scientific data, we're also providing kind of a summary of the rationale for the decision, a lot of information about the labeling, the instructions for use. So we're trying to make all of that information available in a new site, our COVID portal, so that it's easy to access and available for different audiences. We're also making a lot of more detailed information available as quickly as possible. So as well as the initial summary of the reason for the authorization decision, we do publish something we call the summary basis of decision, which is an in-depth overview of the data that Health Canada looked at in order to make the authorization decision. And then shortly after, we're also going to be publishing all of the clinical study reports which were reviewed and contained in the drug submission. So this allows external people to actually look at the data that we looked at so that it can be reanalyzed. And we want to make sure that this is available and supports that transparency and that trust in the regulatory system. Next slide, please. So monitoring long-term safety is a critical part of our activities. So we know that at the time the submissions are received for the authorized vaccines and the vaccines that are currently under review, there are a few months worth of safety data, but the clinical trials are ongoing. So the phase 3 studies, which have supported authorization of the Pfizer and Moderna vaccine, will continue, and participants are going to be followed for up to 2 years. So we are requiring that data to continue to be provided to Health Canada so that we have the full range of safety data. And as I mentioned before, there are specific populations who have been identified as needing additional study, as knowledge gaps where we expect and are requiring the manufacturers to conduct those studies and to provide that data to us, such as children and pregnant women. Now, once a vaccine is deployed in Canada, both Health Canada and the Public Health Agency have a role to look at safety information. So Health Canada has requirements on the manufacturers. The manufacturers have to report any adverse events to us. They also have to follow up with monthly safety reports and any analyses that we ask them to do on specific safety events. At the same time, through the public health system, healthcare practitioners are requested to report adverse events through your local public health, and that information flows up to the Public Health Agency of Canada. And that information, both from the public health side and from the manufacturers, is brought together. So both agencies are working together to bring that information together, to assess it, and to determine if there's any new safety issue or anything that needs further analysis. So as the regulator, we can, if there's new safety information, we can require the manufacturers to conduct additional studies, to provide us with additional information, to update their labeling, or take other risk mitigation measures. So going further, as I said, we continue to regulate the product when it's on the market. So should there be further information, so for example, once clinical studies in children are completed, that data would have to be required to be submitted to Health Canada. We would review it and go through the same process to make a decision as to whether or not the conditions of use could be expanded. Next slide, please. And that's about it. I've got a few links here which will bring you to some additional resources. So an overview of the products, both vaccines and treatments, which are currently authorized or under review at Health Canada. Our detailed regulatory information on the vaccine portal, and there's the link there as well to the vaccine safety dashboard, which is updated weekly and would give you the picture of the safety profile of the two vaccines, which are currently authorized as they're being rolled out in Canada. And with that, I'll stop, and I guess we can take questions.
Thank you very much, Dr. Battle. I would like to encourage everybody who has a question for Dr. Battle on COVID-19 vaccine regulatory authorization process in Canada to submit their question to the Q&A tab that you see on the bottom of your Zoom screen right now. I will start off with a couple of questions that I have. Based on the data that has been submitted to Health Canada, what preliminary evidence do we have to suggest that long-term adverse effects are unlikely?
So as I mentioned, when the submissions came in for Pfizer and Moderna, we had, from the large clinical trials, we had about 2 months worth of safety data. So 2 months follow-up after the second vaccination. We also had data from people who had been in earlier studies. So in the phase 1 and the phase 2 studies, those people had quite several months more worth of follow-up. What we've seen is that for the majority of safety issues, they're seen in the first several weeks after vaccination, and long-term safety effects are actually very rare. But as I also mentioned, we continue to monitor people after vaccination and to require that long-term follow-up from the clinical trials. So that data is continuing to come in, and we continue to look at it as it's generated.
Okay, thank you very much. I see a couple of questions coming in, and the first question that came in is, are people registered for long-term follow-up when they come in for the first injection of the vaccine?
So I believe each province has its own tracking system for tracking people who've had their first doses and to follow up for the second doses. That's not a vaccine safety registry, but the information is there, so people should report any adverse events to their healthcare professional. That information will come to Health Canada or to the Public Health Agency, and that data continues to be followed.
Okay, thank you very much. I see a few questions about AstraZeneca and Novavax vaccines. Are you able to speak to those at all?
I can to a certain extent. So we have a number of vaccines that everyone knows are under review. There's AstraZeneca, there's Novavax, there's Janssen, and there's a submission from the Serum Institute of India, which is a different version of the AstraZeneca vaccine. The AstraZeneca submissions are very close to completion. We are just finalizing those reviews. The Janssen submission is also very well advanced. I think people will be aware that the US FDA will be holding their expert advisory committee meeting on that on this Friday. And the submission to us was more or less aligned with what has gone to other regulators. So I would say in general, we're aiming to be as aligned as possible with other regulatory decisions. But again, a lot of it's dependent on the companies responding to us, providing the last bits and pieces. So I would say hopefully soon we'll have some changes in the number of vaccines that we have authorized, but I can't give specifics.
Okay, thank you very much. There's a question, I'm not sure if you can speak to that, or maybe some additional speakers later in the webinar can address this question, but how confident can we be that the current vaccines in play can address the variants that are currently creating the problems with this pandemic?
Yeah, so that is a challenging question because, you know, people are kind of looking at one variant at a time. So as new information on new variants emerges, we have been in constant contact with the manufacturers of the authorized vaccines and the vaccines that we currently have under review to look for that data on how effective they are against specific variants. So we're getting that information, and if there was any significant information about a specific variant that was really relevant to the Canadian context, that would probably change our labeling or some of our approaches to those vaccines. I think one thing that's really important to remember is that we've got vaccines which have very high efficacy. So if we have slightly reduced efficacy to one particular variant, the overall result depends on the epidemiology, what variants are present in circulation in our environment. But also even reduced efficacy is better than no vaccination at all. So I think that's a really important message. At the same time, all of the regulators are already discussing what do we need to do to have very streamlined processes to adapt the existing vaccines for a booster that addresses variants. So that's also in the works, and it wouldn't require massive 30,000 people clinical trials or starting from scratch with the non-clinical work. There are very streamlined processes where we'll be able to incorporate adaptations to the variants into the existing vaccines.
Okay, thank you very much. A question came in, what new vaccines are in the pipeline and when might we see more versions approved, which is similar to what you spoke already?
Yeah, so I think the next couple of authorizations are kind of the big ones which are under review here and elsewhere. So AstraZeneca, Janssen, Novavax, depending on the data. After that, I'm not sure. I'm not sure what other submissions may be made to Canada. There's certainly lots of candidates which are earlier in development, and we'll have to see how the science evolves from there.
Okay. What, if any, discussions are being held to make the vaccine mandatory?
Okay, so I mean, that's outside of the regulatory role. I would say that there's no, I will let my PHAC colleagues speak to it, but I mean, vaccination is not a mandatory thing in Canada. I think it's a personal choice. What we want here is to kind of reinforce confidence in the system so that people can make that decision on their own.
Thank you. There's a question, what can we say to ensure those with concerns over the expedited review process that the same high standards have been maintained given the time and the process normally it takes?
Yeah, it's a question that comes up a lot. I think so. If we step back, one of the things that has made the entire vaccine development go really quickly is simply the amount of money that's flowed into supporting research and development. So people always talk about, 5 to 10 years to develop a vaccine. A lot of that is taken up with doing a small study, seeing if it's positive, getting funding to do another study, and then moving on. What we've done on the regulatory side is really encouraged adaptive clinical trial designs. So you could be a little bit more streamlined going from your phase 1 to phase 2, phase 3. So not skipping steps, but having them overlap and having a very rapid development for that. Governments have flowed a lot of money to support clinical trials. And I think that's really expedited that part of the process. And then I would say for the review process, Literally, we have been working day and night and weekends for the past year. So for all of our COVID vaccines, all of our COVID submissions, because we've done treatments as well, we've had dedicated review teams who have only worked on those submissions. And we have just put a huge number of resources on doing this quickly so that we could do it effectively. So the scientific review has been very in-depth. It's just, you know, we don't sleep very much, I would say.
Okay, thank you. There's a question about the new information that just came out regarding the Pfizer vaccine and the new information regarding the cold chain. Can you speak to that from Health Canada perspective?
Yeah, so far Pfizer has made a submission to the US FDA to change their storage conditions so that they can be stored at minus 20, so normal freezer conditions for 2 weeks. Health Canada does not have that same submission yet. We're expecting it very soon. And when we have that, depending on whether the data that's been provided to support that is satisfactory, we can expect to review that and make a decision very quickly. So I can't give you timelines now, but I think just like everything else for these vaccines, it will be expedited. And if the data is acceptable, we can make that happen very quickly.
Okay, great, thank you. Can you comment on the data coming in for the pediatric population, and when is it likely they would be offered vaccination?
Yeah, so all of the major vaccines, so Pfizer, Moderna, AstraZeneca, Janssen as well, so they've all started pediatric trials. I recently read that Pfizer had completely enrolled their adolescent trials, so the 12 to 15-year-olds. So we haven't received any submissions of data for the pediatric studies yet, and I haven't seen any releases of the data to support that at this point. I would anticipate that if those trials are, so for example, if Pfizer has been fully enrolled, there would be a few months of follow-up, and then we would expect those submissions. So although I'm not quite sure, I would hope we would see those submissions before the summer or maybe early summer. And then hopefully, you know, like everything else, again, we'll review it as quickly as possible so we can see if the indications can be expanded.
Okay, thank you. I have a question from our attendee, which is sort of a follow-up question to another question. So I will start off with that. Based on the data that has been submitted to Health Canada, are the vaccines safe even if you previously have been infected with COVID-19, but you didn't know, so asymptomatic infection? Are the vaccines safe for that population?
Yeah, so the phase 3 clinical trials for Pfizer and Moderna actually included, they didn't screen out people who had previously been exposed to COVID. So there shouldn't be, there's been no safety issue detected with that, so that should be fine.
And to follow up from our attendee, is there any data to support people who have had COVID-19 on requiring only one dose of the Pfizer or the Moderna vaccine?
No, so there's no data on that, and I think, you know, there's been a lot of discussion about 1 dose, 2 dose. I think that what we can say from the regulatory perspective is that the clinical trials looked at 2 doses, and then discussions about, you know, extending the dosing interval or whatever. That, I think that's a kind of a separate thing, but we can only say from the clinical trials, this is what we know.
I'm going to take you back to the pediatric population, although this is a little bit different from your previous comments about the pediatric population. Any ideas as to when we might have data for pregnant and breastfeeding individuals?
Yeah, so I know that in the phase 3 trials, there were not quite a number. I'm trying to remember the number. There might have been up to about 100 women who got pregnant during the clinical trials for Pfizer and Moderna. And there is ongoing follow-up of those people and of the outcomes of their pregnancies now. I don't believe we've received that data. we require the manufacturers to continue to follow up and to report specifically on events of pregnancy as part of their monthly safety reports. Pfizer has just started a study in pregnant women. Just last week it was announced. So again, that data is being collected. We don't have a lot of information now, but over the next couple of months, we can expect to see some of that data, at least probably the outcomes from the women who became pregnant during the initial studies.
Okay, great. This will be the final question for this Q&A, and I will finish this Q&A with, are there any data submitted to Health Canada that suggests that the vaccine prevents infection or reduces the risk of transmission of COVID-19?
Not yet. So the clinical trials, the phase 3 clinical trials for Pfizer and Moderna, their primary endpoints were looking at symptomatic disease. So there may have been some secondary endpoints looking at viral load, but there's not a lot of information at this point about transmission or about asymptomatic disease. I think that will come, especially as we're seeing these being rolled out more broadly, but that data is not available yet.
Okay, well, thank you very much for all attendees who submitted their questions, and to you for presenting today on this important topic. And now I would like to move on to the second presentation. And I would like to invite Dr. Shelley Deeks for the second presentation to join me right now. Dr. Shelley Deeks is a public health surveillance medical officer of health in Halifax, Nova Scotia, and she's a vice chair of the National Advisory Committee on Immunization, NACI. She will present on the role of NACI on COVID-19 vaccine guidance development. Welcome, Dr. Deeks.
Thank you very much, and thanks for inviting me to present. As Alexandra indicated, I'm going to be talking about the role of NACI in general, and then as it pertains to COVID vaccines. Next slide, please. I don't have any declarations of interest other than I'm a very strong vaccine supporter. Next slide, please. Okay, so the objectives of my presentation are I'm going to provide you with an overview of NACI and its role in COVID-19 vaccine planning, including our role in the FPT landscape of bringing vaccines to Canada, our processes, including the representation of memberships and how we look at evidence. Then I'll go into focusing on the guidance that we have released to date and upcoming guidance on COVID-19 vaccines and our ultimate role in creating Canada's immunization guide, which is the Canadian Immunization Guide. Thanks. If we can go to the next slide. Okay, so you've seen this slide with the last presenter in terms of what is involved and who brings vaccines to Canadians. So Dr. Bettel focused on the Health Canada role. I'm focusing on the middle role, which is the Public Health Agency of Canada. NACI is an advisory committee that's made up of experts in from various areas of specialty, and we make recommendations to the president of the Public Health Agency on the use of vaccines that have been authorized in Canada. So we report through to the Public Health Agency of Canada. PHAC also has a role, as was described by Dr. Bettel, in terms of vaccine safety surveillance and working with the provinces and territories. While NACI does not have a role in that space, we hear through the Public Health Agency of Canada and the NACI Secretariat about updates with respect to vaccine safety and epidemiology as it pertains to the vaccines that we are currently focusing on. Health is a provincial and territorial jurisdictional issue. So it's up to the provinces and territories to determine publicly funded vaccination programs within their jurisdictions. And they are also responsible for funding the vaccine, distributing the vaccine, and delivery. I just want to point out one area from Dr. Bettle's presentation where she indicated that providers may report vaccine safety, adverse events following immunization to the local jurisdictions who report to the provinces and territories who report through to PHAC. In some provinces and territories, it is a legal requirement to report vaccine adverse events following immunizations. And so it's important in your jurisdiction. I mean, everybody should be reporting adverse events following immunization, but in certain jurisdictions, healthcare providers and immunization providers are legally required to report those events. Next slide, please. So Dr. Bettle also talked about the expedited vaccine development and deployment process. This is just a schematic about that. And I would agree that there has been the expedited review has been unprecedented in Canada and elsewhere in the world. And part of that, a large part of that is the unprecedented money that has flowed to industry and as well as human resources in the various groups that are responsible for reviewing the data. But the other piece that I think is important to recognize, and Dr. Bettle mentioned this as well, is that there's rolling submissions. So the vaccines are being authorized at an earlier part in the trajectory of a clinical trial than they would have. The reason that I'm pointing that out is because you will see when I get to it that the National Advisory Committee on Immunization is making vaccine recommendations. But unlike a traditional vaccine where all of the or most of the information is available, for COVID, we will be making our recommendations will evolve and change as the evidence accrues and changes. And that does not mean that that the previous recommendations were wrong. It just means that now there's additional information. There'll be additional information as for safety, because right now the trials have been only followed for a relatively short period of time. As we get additional information about safety, we'll be able to update our recommendations. As we get additional information about efficacy or effectiveness, so efficacy from the clinical trials, effectiveness from some of the population or studies that are happening post vaccine being implemented in populations, we will also be able to change our recommendations. So that is all a very specific result of this expedited vaccine development and the way that that data are accruing and the way that we're continually looking at the data as it comes in. So you can see that in the little orange arrow, that is NACI's review. And we then make our recommendations. One thing that I'd also like to highlight, it's been amazing with COVID. We have had unprecedented linkages between the regulator, who is Health Canada, and the NACI committee members, so that we are really working hand in step with the regulator in terms of getting information very, very quickly. And that has also really helped with ensuring we're able to make recommendations and release them to the provinces and territories, as well as the general public very quickly. We've been trying to release them within within a week or 1 and 2 days actually of a product being authorized under the interim order. Next slide, please. So Dr. Bettel focused on the regulatory review. This slide just shows how the NACI advice is similar but different than the regulatory review process. So what NACI will do is we'll recommend vaccination strategies to promote health and prevent and control the infectious disease that the vaccine is targeted against. The regulator focuses on the individual use of products, whereas at NACI, we focus on the use of a vaccine for at the population level, so publicly funded programs, as well as at the individual level. So for COVID vaccine right now, we're really focusing on the population level recommendation. But for traditional vaccines, we look at the population level recommendation and individual level recommendation. We look at the data from the clinical trials and any of the data that we have access to. But we also look at disease burden information, disease distribution, ethics, equity, feasibility, and acceptance when we're making our recommendations. NACI can and does make off-label vaccine recommendation when there is a specific need supported by the vaccine characteristics, epidemiology, and public health ethics analysis. There is a number of instances that the committee has made off-label recommendations. One recent one that's non-COVID specific that I can give you an example of is for Shingrix vaccine. The committee indicated that Shingrix should be used for individuals that were immunocompromised, whereas the product wasn't specifically licensed for that population. So that would have been considered an off-label recommendation. More common off-label recommendations are recommendations that are at a different age grouping, that target a different age grouping than the authorized indication. We go to the next slide. So NACI is Canada's NITAG. So National Immunization Technical Advisory Groups, or NITAGs, are established in many countries. So they are established in 134 countries, and they are recommended by WHO. There's a global NITAG, which is the SAGE, or the Strategic Advisory Group of Experts, that is convened by WHO, and but many countries have their own NITAG. And indeed, in Canada, we have some provinces that have provincial immunization advisory groups. NACI is one of the longest standing global NITAGs, and we've been in existence for over 50 years. And the biggest change for us as a committee occurred actually recently, where we expanded our mandate to include considerations of ethics, equity, feasibility, acceptability, and economics. So we talk about NACI's expanded mandate, and that has, as a result of that expanded mandate, we've added members with specific expertise. Go to the next slide. So this slide just shows, it's a schematic of the components of that we look at when we're making recommendations. So the kind of more purpley color ones on the left are our traditional components in a NACI recommendation. So the burden of the disease, vaccine efficacy, vaccine effectiveness, immunogenicity, vaccine safety. And NACI has always looked at those components when we're making vaccine recommendations. However, as of 2019, with our expanded mandate, we're also looking now systematically at acceptability, feasibility, economics, equity, and ethics. So our statements are much more fulsome, and we're hoping provide much more utility to provinces and territories when they make the determination about what vaccine should be publicly funded within their jurisdiction. Next slide. So PHAC appoints voting members, a chair and vice chair. Members are appointed for 4 years with one optional 4-year renewal. The chair and the vice chair are both 2-year positions with two 1-year optional extensions. We currently have 15 members as well as the chair. So the chair is not considered a member in and of themselves. So you can see the listing there of the expertise that the members bring. So we have 2 pediatric ID, 2 adult ID, 1 allergist immunologist, 1 pharmacy expert, public health nursing, pharmacoeconomics, public health and preventive medicine, and so the groups that have been added from an expertise perspective, given our expanded mandate, are a member representing epidemiology, social sciences, and pharmacoeconomics. We also have a number of liaison representatives that have a role in immunization, and an example of which are listed on this slide. So the CPHA, the Council of Chief Medical Officers of Health Canada, Canadian Pediatric Society, and the College of Family Physicians of Canada. And then we have 6 non-voting ex officio federal representatives. The liaison representatives are also non-voting. So that includes representatives from Health Canada, PHAC, Indigenous Services Canada, and National Defence and Canadian Armed Forces. Go to the next slide. So we have a very approach to conflict of interest, which is critical for any immunization advisory committees. Every year, members complete an annual declaration of interest statements. Those are reviewed by the NACI executive. And in an ongoing way, members are asked to declare any new relevant interests to the NACI Secretariat as they emerge. And then further, at every meeting, the chair asks members to declare any relevant conflict of interest at the beginning of each meeting. So member declarations are assessed by the executive committee, and there is feedback given to members. If conflict of interest are identified, management strategies are applied. So some examples of that could be that a member might not be asked not to participate in a certain working group, or they may be asked to recuse themselves from a vote on some specific topics if the conflict has been identified. Next slide, please. So in terms of COVID vaccines, we've been providing ongoing guidance to public health decision makers on many aspects of COVID vaccine, and these are all housed on the NACI website. All you need to do is Google search NACI, and it actually comes up, NACI immunization for NACI Canada. So we have completed 3 groups of recommendations. The first is research clinical trial priorities for COVID-19 vaccine, and that was completed, I think, it's all a bit of a blur now, but I think that was in the late spring, early summer. We've completed a preliminary guidance on key populations for early COVID-19 immunizations, and that was completed in, I think, August or September, prior to any vaccines being authorized for use, and guidance on prioritization of initial COVID vaccine doses. And then we have an ongoing process to complete guidance for COVID-19 vaccine and specific products. And we continue to update guidance on key populations for immunization. We go to the next slide. This is a screenshot of our webpage that I was just referred to. And you can see the current vaccine statement. That statement is not, unlike other vaccines, we're not embedding that within the Canadian Immunization Guide. And the reason is it's an iterative statement and continues to be updated. So the statement is on our on the NACI website. And the most current version is on the main web page. Right now, the current version is January 12th. The archive version, we're on our third version right now, are also available on that page. You just need to click on the link under previous versions. In terms of prioritization statements, again, those are evolving as further information about the vaccines are and vaccine supply are accrued. And as part of the prioritization guidance, we are looking at, the committee is looking at an evidence review to make sure that we consider the populations that have been the evidence behind risk factors for the disease. If we go to the next slide, this also gives you an example of the various guidance. So as I indicated, this is actually an old. We mustn't have gotten the update of the deck, but updated COVID-19 vaccine guidance isn't available through CIG. It is available on the NACI website. The vaccine guidance goes through our normal, the normal steps. So we have vaccine administration section, vaccine safety section, vaccine efficacy section, and as well as all of the items that are listed here. We're looking at extended intervals between doses. There's a vaccine and allergy section, anaphylaxis management, and including vaccine during pregnancy and breastfeeding, and interchangeability. So while all of this information is included in the current statement, NACI is actively looking at a number of these issues as evidence emerges. And one of the issues that we're looking at now that one of the participants actually asked about is whether we need to make any changes in our recommendation for individuals who previously had confirmed lab confirmed COVID-19 vaccine. COVID-19 infection. Currently, we indicate that the vaccine is recommended for individuals who have who've had a past history of COVID-19 disease, but the committee is looking at that evidence as further information is available. Next slide. I basically mentioned this. Our base statement is a living document. It's continually revised, and you should be aware that it will continue to be revised. And that is a good thing because we are revising it very quickly as evidence emerges. So I mentioned the issue that one of the issues that we're looking at is is whether we need to make any modification about for people that have been previously affected. We're also looking at intervals. We're also actively looking at interchangeability. The appendices are important for providers because they contain the detailed information about the clinical trials, including safety information. So these are not small documents. The current statement is an 88-page, quite dense document, but they provide a wealth of information for providers. If you go to the next page. The Canadian Immunization Guide is our ongoing resource, and it continues to provide a lot of information about all vaccines, but also some fundamental information about vaccine safety, vaccination of specific populations, and passive immunization. So there are certain times in the COVID statement that we will provide links to the Canadian Immunization Guide. And ultimately, hopefully, the COVID vaccine, when it's not a statement, will be integrated in the guide when it's not, when we're at a more stable period for this vaccine. Next slide. That is all for me. I'm happy to answer any questions.
Thank you, Dr. Deeks. So again, we will enter into the second Q&A session of this webinar. For all of you who would like to pose a question to Dr. Deeks on the role of NACI on the COVID-19 vaccine guidance development, please do so using the Q&A tab on your screen. And I will start off with the first question that is in my Q&A box here. I'm not sure if you can speak to this, or maybe we can leave it for another speaker, but when you have been previously vaccinated, can you still spread the virus? Can you speak to that at all, Dr. Deeks?
Yeah, I think that the first speaker talked to that a little bit. We do not know yet whether the vaccines have efficacy against asymptomatic transmission. There has been preliminary evidence for Moderna after one dose. That is, this is also included in the NACI statement, that is promising that the vaccine will actually be efficacious against asymptomatic transmission, but unfortunately, we do not know that yet. It is an outcome that is, it's actually a primary outcome of some of the clinical trials, but given that the data that had been presented to date was interim, that the data for that endpoint hasn't accrued yet. So it's a watch this space.
Well, thank you for elaborating a little bit more on this. Moving on to side effects, how does NACI share adverse effects data related to the COVID vaccine?
So it's not really up to NACI to share adverse event data. If I am understanding the speaker's question correctly, provinces, from a vaccine surveillance perspective, provinces and territories report up to the Public Health Agency of Canada, as well as Health Canada. And there is passive safety surveillance, but there's also active feedback through other networks in Canada, including the Special Immunization Clinic Network. And through that FPT system, there is active monitoring of vaccine safety surveillance, and it's being pushed out on the Public Health Agency of Canada's website, as well as some provinces' website. I know in Ontario, they are producing data weekly on adverse events. At NACI, in our statements, we have a lot of detail, a summary about vaccine safety from the clinical trials, and in the appendix, I think it's Appendix A and B for the mRNA vaccines, there's very specific information about the vaccine safety from the clinical trials that's contained in the NACI statement. We will also hear the evidence from PHAC about the the post-marketing surveillance that has been collected as it accrues.
Thank you. A question about NACI guidance. How can we be advised when NACI guidance is updated? I think you spoke to that a little bit. Is there something we can subscribe to receive notification when the guidance is updated? Is a question that came in.
Yes, so I believe, I'm not a public health agency employee, but I'm pretty sure that you can just subscribe. I know you can subscribe to the Canadian Immunization Guide updates because I get those, but I'm pretty sure you can do it overall for the NACI updates as well. And so you just go to the site and subscribe.
Okay, thank you. We have a question from Dr. Ian Gemmell. He is thanking you for your presentation. He says it's a great talk. He says that you mentioned that NACI does recommend vaccine for coronavirus for people with previous infection. Are there data about immunizing people who have long-term sequelae and not yet fully recovered, i.e., are there any concerns identified?
Thanks, Dr. Gemmell. In terms of that question, that is an active, ongoing review. So that is something that the committee is looking at now. In terms of our recommendation, in the current guidance, people need to be stable to receive the vaccine. And so that piece of it, if you're asking about individuals with who are hospitalized, I suspect those individuals, if they're hospitalized currently actively with COVID, wouldn't be getting vaccine. But there are no data that I'm aware of, and Marina may in her talk get to this, but there are no data that I'm aware of individuals with long-term sequelae that actually have been vaccinated. Individuals that were known COVID cases were actually excluded from the clinical trials. There are people that were included that were serologically positive, but anybody that was PCR positive were excluded from the mRNA trial. So that data is accruing as the vaccine is rolled out from a population perspective.
Okay, thank you. Moving to the top of the Q&A tab, a question about the 15 minutes waiting period for the vaccination. Are all countries watching all patients for at least 15 minutes after vaccinations? Are we reviewing whether this is still needed? Your thoughts on that from NACI's point of view?
Yes, so I can't really speak to what all countries are doing. I'm having a hard time keeping on top of everything in Canada as opposed to what all countries are doing. But it's pretty much a standard of care that countries do wait for at least 15 minutes for vaccination. The issue that we've been grappling with really is the extended interval. So there's been no suggestion that we do away with a 15-minute interval. Because we know that anaphylaxis occurs quite quickly in the majority of cases, but we have provided feedback of a 30-minute interval for a certain subset of the population. For instance, individuals that have had allergic reactions to other vaccines.
Okay, thank you. A question from attendee. I only see alternate interval of 28 days for Pfizer vaccine. However, I have heard 35 days and up to 42 days. Could you please kindly clarify?
Sure. So in the NACI statement, we have indicated an interval. There are intervals that are in, and I can see how it can probably be confusing. There are intervals that are actually in one component of the statement, which are the routine intervals, which I think the attendee that answered that question are referring to. But we've also indicated that that an extended interval can be considered, and that is where the 42 days comes into play. And then the committee is actively discussing whether we can extend that interval beyond the 42 days, and looking at evidence from a number of countries, as well as some of the, not evidence, looking at what a number of countries are doing, because as many of you are probably aware, countries are landing at different places for the intervals. So we're looking at an environmental scan of what countries are doing, but also looking at evidence that has accrued within Canada as well as some other countries. Thanks.
Okay, thank you. A question from the attendee: what would be the recommendation on getting COVID vaccine with other vaccines? Are there any guidance on that right now? Could you speak to that?
Yep. So that is also included in the NACI statement, and we are indicating that at this time it's best likely not to give COVID vaccines with other vaccines, and the interval is included. And that's just because none of the clinical trials had co-administration study, so there is no co-administration. And given we're approaching this from an abundance of caution, and given that it's quite a scarce resource, and we also need to make sure that we are able to report adverse events. We don't want to be in the situation where we confuse adverse events from one vaccine with another vaccine. So at this time, we have recommended not to co-administer COVID vaccine with another vaccine.
Okay, I have to take you back to the extended interval, as there's many questions on that. Can you comment if this is in the realm of your, capacity within NACI? How do provinces get approval for the extending of the interval between the two doses to, for example, 42 days?
So that's not really within the scope of NACI.
Okay.
Yes, NACI, we make the recommendations. It's up to the provinces and territories to implement those recommendations, okay, to determine what the program is. So they'll define their program in the province and then implement it. Okay.
Further, could you comment on the dosing interval being expanded and the, negative consequences of that, if there could be any?
Well, that's the exact conversations that we are having we're having right now. So that's more a watch this space, because it is a tricky situation in that vaccines have been authorized and been studied using specific intervals, but we also are in the middle of a pandemic, mm-hmm, and with a very scarce resource, and people are dying of COVID-19. So we need to make sure that we look at the evidence and be guided by the evidence as well as ethics and equity, and look at all the potential consequences of extending the interval. We not only will be looking at COVID evidence and vaccine effectiveness data that's accruing, but also looking at what we know, which is quite a lot, from other vaccines and the immune system.
Okay, thank you. A question, this is a long one, I'll read it straight out of the Q&A tab. Although a 90-day period between infection and vaccination is recommended, NACI has said vaccine can be offered to remote First Nations communities as long as 10 days into infection has passed and the individual is symptom-free. Who is involved in the decision of determining if the community is considered remote enough to change this requirement?
So again, that's not really a NACI discussion. That's more an FPT discussion that maybe the PHAC representatives can address.
Okay.
We make the recommendations, and it's up to the provinces and territories to implement. And I know and I think that you, through this webinar series, have had the speakers come from the Public Health Agency of Canada that talk about some of the more operational considerations. And that would be one of those. And we would provide advice as requested as a committee. But the issue for some of the remote and isolated communities is the challenges of getting a vaccine, particularly one with stringent cold chain requirements, to the community. You would not want to miss the opportunity for vaccines. You have to weigh missing the opportunity for vaccines with what evidence we have versus what components are unknown, and almost make a risk-benefit decision.
Thank you. We're almost out of time for this Q&A, so I will finish off with one last question for you. How could you speak to how can vaccine providers and healthcare practitioners reassure people about the safety and the effectiveness of the vaccine, especially lacking the long-term safety data?
I think as healthcare providers, we need to be very, very open and transparent with our patients. I mean, we do know a lot about this vaccine. We need to and provide, like, all of the information of what we know is actually available on the NACI website and in the NACI statements. But I think we do need to be open and transparent about some of the unknowns. We do not know the duration of protection. We do not know about long-term vaccine safety implications because the vaccine hasn't been administered for a long period of time. However, we are monitoring and will take action if any action is needed. So I think that it's really important that we all immunization providers get familiar with this vaccine because it's for these vaccines, because there's going to be a lot of questions, but also be transparent about what we don't know. Thank you.
Okay, thank you so much. We have to move on to stay on time with our agenda. So thank you very much to Dr. Deeks for her presentation, and for all of you for submitting your questions. And now finally, for the final presentation, I would like to invite Dr. April Kelly and Dr. Marina Salvadori to present to us on the vaccine technologies in Canada. Dr. April Kelly is a technical lead, and Dr. Marina Salvadori is a clinical lead for SARS-CoV-2 at the Public Health Agency of Canada, respectively. And I welcome you to present on COVID-19 vaccine technologies in Canada.
All right, thanks very much for having us today. It's a real pleasure, as always, to get to talk about vaccines during this pandemic. So neither April nor I have anything to declare, but much like you all, we really hope that vaccines are a way at least partly out. Our objectives today are to describe the SARS-CoV-2 spike protein as a vaccine antigen, and to discuss all the different vaccine platforms and technologies that are coming on board in Canada, so that hopefully you can answer questions when you are asked by your the patients and people coming in to get vaccinated with you. And
okay,
over to you, April.
Thanks, Marina. We're just so eager. So let's talk first about the vaccine antigen, the spike protein. So So you may have seen something like this before. So the virus that causes COVID-19 is called SARS-CoV-2. And there's a picture here showing these viral particles, and on the surface are these little spikes, literally kind of spikes. And showing right here on the right-hand side is a picture of what the virus looks like with the spike protein on the surface. And so when we're thinking about, okay, what's a good antigen for our vaccine, this spike protein really stands out, because the idea is the spike proteins on the surface of the viral particle makes contact with your host cells via this spike protein, and the spike contacts the host receptor, the ACE2. So if we can interrupt that connection, potentially with anti-spike protein antibodies, then we could prevent infection. And that's kind of what we think about in terms of neutralizing antibodies, is they neutralize the ability of the virus to infect. So we want to elicit these antibodies with vaccination, such that when you experience potential infection, you're protected. So this is very classical vaccine theory, where you give the spike protein, and the spike shown there on the left in that little blue tulip little picture. And when your body sees the spike protein, you get a primary immune response. And then upon natural infection, you'd mount a much larger, hopefully protective immune response. So that's the idea behind using the spike protein as the antigen. We will say, though, that there is no correlative protection. So there's no test you can do for vaccinated folks to say, oh, you've got an adequate level of protection, an adequate level of anti-spike antibodies, you're good to go. We're still really determining what that science could look like. And as Shelley mentioned, and a lot of the speakers have mentioned, this is a really fast-moving field. So we're tracking a lot of different questions quite closely. So how could we deliver the spike protein? And there's a few different ways. And I like to think of it kind of like all roads lead to Rome, right? Where you can deliver the protein itself. And that's kind of that tulip-looking thing at the top of the slide. But you could also give mRNA that encodes for the spike protein. And the mRNA is translated inside your cells into the spike protein. You could also give DNA that encodes your spike protein. And the DNA is transcribed first into mRNA and then translated into proteins all inside your cell. But no matter what you get, you're going to end up with that spike protein to elicit anti-spike immune responses. So it's worth noting that these different processes, transcription and translation, they happen in different parts of the cell. So transcription only occurs inside the nucleus of your cells. So if you get a DNA vaccine or a vaccine that has DNA components, it needs to make it into the nucleus. Similarly, translation only happens in the cytosol of the cell. So in order for mRNA vaccines to work, they need to get inside the cytosol of the cell. So, and without help, without specialized technologies, DNA or mRNA, they don't naturally just float into your cell. They need help. They need a certain conduit mechanism. And so vaccine developers have developed novel technologies to allow the spike protein mRNA or DNA to enter into the right component of your cell. So lipid nanoparticle technology has been developed and used by vaccine developers of mRNA technologies to get that mRNA into the cytosol of your cell. And then viral vector technology acts similarly to get the DNA that encodes the spike protein into the nucleus of your cell. So we'll put this into context later, but this is our foundational background. And over to you, Marina.
Okay, thanks. So now I'm going to go through the different vaccine platforms and how they work. So next slide. April, next slide. Okay. So Canada right now has agreements in principle with 7 different vaccine developers to supply Canadians with doses of vaccine if the vaccine candidate ends up going through clinical trials and is assessed to be safe and efficacious by Health Canada. So the vaccines in development for which Canada may have first access use 3 different vaccine technologies. So there's protein subunit ones, including virus-like particles, and we're going to go through those. Messenger RNA, which we're all now familiar with, our first 2 vaccine, Moderna and Pfizer, and viral vector platforms, which are AstraZeneca and Janssen. So we're first going to talk about the protein subunit vaccines, which we have yet to have any in Canada, but the one that's first in this race so far on a global stage and has submitted to Health Canada on a rolling basis is Novavax. So basically, this delivers vaccine directly as a protein, and you inject the protein with or without an adjuvant, and you usually get quite a strong immune response. This is the traditional platform for the most part. It's sort of the basis of all or many of our previous vaccines. They generally have slower manufacturing timelines, and it's quite an established technology, though there are a few tweaks and improvements that are being made with these new coronavirus vaccines. Next. So the other one in this group is Medicago. Medicago is a virus-like particle. So essentially, it takes the protein, the coronavirus spike protein, and has a little tail on the end of it so that it self-assembles and makes itself into a virus-like particle. So it looks like a virus. It doesn't have any of the genetic material that you would have inside a virus. It's just basically the outer shell of the virus. And so it mimics the virus, and then that goes, is injected, and it directly elicits an immune response. This is the first time that this viral-like protein will be made in a plant-based medium, which is what Medicago is doing, but this is an established technology. For example, HPV is a virus-like particle platform. It also, they deliver a strong antibody response. It sometimes uses adjuvants, sometimes does not. This Medicago product will use adjuvants, and they generally have slower manufacturing timelines. So the messenger RNA platform, with which we're all familiar right now, is the fastest and first one out of the gate. And as we all know, this is a brand new technology, and this is really the first time that messenger RNA has been used in a successful, widely rolled out platform. So essentially what we do is we take a messenger RNA, which codes for the coronavirus prefusion spike protein. We wrap that messenger RNA inside a lipid nanoparticle. This is also a really important new advancement in this technology. So this is required because otherwise the mRNA just breaks down very quickly. It's actually very reactogenic and just immediately breaks down and never makes it into the cell to work. So when it was wrapped with this the lipid-based nanoparticle, it allows it to go and transverse through the cell membrane, go inside the cell, where the inside payload of messenger RNA coding for the spike protein is delivered. Then inside the cytosol, it finds a ribosome. The ribosome is translated into a coronavirus spike protein. And then that protein goes out and is displayed on the cell membrane with different MHC class 1 and 2 proteins, which help activate different parts of the immune system. So we know that this type of technology activates both B cells and T cells, or antibodies and cell-mediated immune response, and it has a very rapid manufacturing timeline. And that is part of the reason you may hear that if there are variants of concern that require a new vaccine, this technology will be able to very quickly pivot and incorporate new variants potentially. The two ones that we have right now are Moderna and Pfizer-BioNTech, and you're all very familiar with those. Okay, sorry, next slide, April. Okay, so viral vector vaccines are being used elsewhere in the world. The ones that are currently, we have agreements in place are the Janssen, Johnson & Johnson product and the AstraZeneca, also known as the University of Oxford. But other ones that use this are Sputnik is another example of this. So basically what happens is that the coronavirus, we take out the part of its RNA that codes for the spike protein. We translate that into a piece of DNA. we take that DNA and we put it inside a virus that we have now mutated so that the virus can't replicate anymore. So basically, we're making a little piece of DNA that codes for the coronavirus spike protein. And we made this our delivery truck that can't replicate. When it gets injected, it goes first through the outer cell membrane, and then it goes into the nucleus and releases that piece of DNA. That piece of DNA then gets transcribed into a piece of messenger RNA. That then leaves the nucleus, floats around and finds a ribosome, and then the ribosome reads it, creates a coronavirus spike protein, which then gets displayed on the cell wall again with these MHC 1 and 2 cell apparatus to turn on both B and T cells. So again, we have antibodies and cell-mediated immune response. And there is some concerns with this one. The main concern with this one is that some people may already have antibodies or immunity against the vector or against the adenovirus. So there's a question when we use these of, does pre-existing immunity make a difference? And that's actually a very hard thing to know in a population. And so we, that's just one of the questions that people have. How many times can you keep giving the same vector? Next slide. So how do we look at if vaccines work? So, everybody and the patients just want to know is, does it work and is it safe? So how does it work? There's two ways that we figure out if a vaccine works. We look for vaccine efficacy and vaccine effectiveness, and they're slightly different. Basically, vaccine efficacy looks at, it's an experiment or a randomized controlled trial, and it looks in a perfect and as well controlled as we can possibly do situation, and says, what is the very best response we can get under controlled circumstances? Vaccine effectiveness, we're just starting to see now. And those are looking basically at how does a vaccine work in the real world now that it's being rolled out with all of the inherent issues as we roll things out in the real world. And this looks at vaccinated versus unvaccinated people in different trial designs. So basically, just to go over the randomized controlled trial, you take a whole group of people, you give half of them placebo or a fake and half of them vaccine, and then you see if they're protected. So you can see here that in this particular picture, 7 out of 8 people got disease in the placebo group and only 1 did in the vaccine group. So the vaccine efficacy was 86%. Over to you, April.
Great, thank you, Marina. Sorry, it's anyway, thank you, Marina. Sorry for being slow on the slides. This slide covers the current COVID-19 vaccine development landscape as of the end of January. This hasn't changed too much in the few weeks that have passed since then. But on the left-hand side, it shows all the different manufacturers grouped by their vaccine type. And so some of these names are familiar from what Marina just talked over with the different platforms. But also showing whether they have submitted to Health Canada under the interim order, which you heard from Dr. Bettel, and also where they are in the what clinical stage of development that they're in. So you can see a lot of vaccine developers are all stacked up along that phase 3. They're quite advanced. And this is really amazing given the rapid timelines of this development. You can also see with those red arrows which vaccine developers have submitted under the IO to Health Canada, and 2 have been authorized, and Moderna and Pfizer. A lot of this information has been covered before, but just to put into context as to where they are in the landscape of global vaccine development. So now we're going to talk through, we've talked through the platforms and the different technologies, and now we're going to talk through the vaccines themselves. So as you've heard, mRNA vaccines, the 2 vaccines of this type for which Canada may have early access are Moderna, Pfizer, BioNTech, and they're both authorized right now. And they're made of 2 primary components. The first is the mRNA encoding the SARS-CoV-2 spike protein. And as you may know, mRNA is very unstable. And so the second part of this vaccine, the lipid nanoparticle, provides two functions. The first is to stabilize it so that this vaccine actually makes it from the vial into the needle into your arm, but without degrading. And the second function is that this lipid nanoparticle allows the mRNA to enter the cytosol of your cell so that you actually produce the antigen via translation. But like oil and water, lipids don't mix very well with water. So the mRNA lipid nanoparticle vaccines have special frozen storage conditions and handling requirements. For example, don't shake them. so those are the mRNA vaccines. Now we'll move on to talking about viral vector vaccines. So as Marina mentioned, this is AstraZeneca and Johnson & Johnson for early access for Canadians. Neither of these vaccines are currently authorized, as you may know. So first part of the vaccine, as Marina mentioned, is the vaccine antigen is encoded by DNA, which is part of that adenovirus vehicle. The DNA is more stable than mRNA, but it can't get into the nucleus of the cell without help. And so we can think about this type of vaccine in two parts. The DNA part encoding the antigen and the non-replicating viral vector, the adenovirus. And adenoviruses are more complex than lipid nanoparticles. They've got a few bells and whistles that allow them to be stored at higher temperature, meaning in refrigeration, or I think they're even stable for some amount of time at room temperature. So this type of vaccine has slightly different characteristics from the mRNA vaccines. And finally, we have protein-based vaccines, Novavax and Sanofi, neither of which are authorized currently in Canada. And these, as Marina has said, are more familiar vaccine technologies. Your protein antigen is pretty much straight up. You don't have any kind of cellular processing of your own cells. But like other protein-based vaccines, they may require the use of antigens to induce a strong immune response. And so listed there are some adjuvants under consideration with these vaccines in development. And finally, we have a type of protein-based vaccine, which is a lipid nanoparticle. Excitingly, this is coming from a Canadian company, and where the lipid nanoparticle is coming produced in plants, which, as Marina said, is a novel mechanism for that production. So this spike protein looks a little different. It's similar in the way that it would induce immune responses, hopefully that are protective against the spike protein, but it also has a little insertion at its base such that the spike protein is able to form this virus-like particle formation as it's produced in plants. And just like other protein-based vaccines, it may require, I think we know it will require an adjuvant, and that's listed there. So to summarize, I'll hand it back over to Marina.
All right, so basically we've gone over the three platforms that are being used right now for COVID-19 vaccines. We know that so far the antigen that was first picked seems to have worked, and that's the SARS-CoV spike protein antigen. And that seems to have induced protective efficacy in randomized controlled trials. We have also negotiated agreements to supply vaccine from all three different types. And right now we're starting to learn through both randomized controlled trials and real world effectiveness studies, how these vaccines work and how best to deploy them in different populations. So I think there we will take questions. I'm not sure who's asking them. I think it's Alexandra. Here are some of our additional resources.
Thank you, Dr. Salvadori. I welcome Dr. Kelly to join us right now. And same thing for all of you who are watching. If you have specific questions regarding COVID-19 vaccine technologies for our experts, please submit them now in the Q&A tab. And I will start off with a question. Hearing a lot about messenger RNA vaccine and not knowing if it can change or damage DNA. Has this been studied? Could you speak to that, please?
Right. So because the messenger RNA does not go inside the nucleus, it is not felt that it will have any effect on the cell. It just floats around in the cytosol, and it really should not ever integrate inside. This has been fairly well studied. Obviously, these have been done very, very quickly, and there are missing pieces to our knowledge base as a whole human society. But the thought is that the messenger RNA will not enter into the nucleus and should not affect the cell, like a person's cellular integrity. April, did you want to add anything?
No, that's great, Marina.
Okay.
So just to follow up on that, a question from our viewer, is there, sorry, my screen just moves around. The questions are moving around and it's really difficult to keep your eyes on one. Is there a risk for the host gene alteration by the DNA-based vaccines, such as the ones from AstraZeneca or the Johnson & Johnson that are in the pipeline?
So there is a theoretical concern about that because it does have to go inside the nucleus, though it is transcribed not by integrating into your actual DNA, but by floating around and using soluble factors that then translate it into mRNA. But it is a theoretical concern. There have been lots of previous studies of these sorts of vectors, and they've been used for other applications. And so it is felt to be a very, very unlikely occurrence. And obviously they wouldn't be authorized or used if it was felt to be a real and serious danger. So that's about what we can say right now. It's felt that it is unlikely, but theoretically, it could be very rarely possible. April?
Yeah, I guess I'll just add to both of those good questions is that, the Health Canada reviewers look at the submitted data or the toxicology and the different types of studies that manufacturers are required to submit. They look at them very carefully. And so this is something that has been flagged and examined carefully, and we'll see if and when a decision is made that it would be based in full knowledge of those data.
To follow up on that, another question, I guess it's in the same area. Is there any data to suggest that these viral vector vaccines could be oncogenic?
So that's really the same question. They certainly would never have proceeded in any way if people thought that they could be oncogenic. And there has not been any signals of that in any way. And we don't think that they are, but that is the point of long-term safety studies. So at this point, I think it is a vanishingly rare possibility. And it is not the viruses themselves were chosen very specifically. They're ones that don't integrate into the host DNA, et cetera, and there is no signal of any sort that would happen. April?
Yeah, I guess, we get the opportunity to multiple kicks at this can, so that's good. But, these viruses, particularly the Janssen virus, the adenovirus 26, this is something that we may have seen in the community. And it's not, the delivery track that Marina mentioned is altered in a way that it doesn't replicate, but we would see them in the wild when they do. And so we're not seeing signals there. And so this is actually an even safer version of those. So hopefully that gives people the idea that this may not be a large concern in this context.
Okay, thank you. Question on the top of your screen, if you can see it and follow along. In the evidence that has been publicly released so far, it seems clear that the clinical efficacy of the Pfizer-BioNTech and the Moderna will be greater than for the other vaccines that are coming, such as the Novavax, Johnson & Johnson? What should we tell patients concerned about getting a less efficacious vaccine than when the new vaccines are approved?
I think, that's a very excellent question and one that we're all struggling with right now. So I think that there's a few very important things. At this point, it seems to me in Canada that we are all in agreement that no vaccine should be mandatory, certainly now until we know more. It's always a matter of personal choice. And I think that informed consent of the patient is really important. So it's really a personal choice for you. Does the person want a higher efficacy? They have to balance their risks, how much they can mitigate the risks. Can they work at home? How careful are they about wearing masks, etc. And we have to inform them about how long they have to wait for a different vaccine. So that's really quite a difficult moving target. I'm going to be honest, there's a lot of commentary out there, and it's really been a topic of huge debate, right from the WHO all throughout. A lot of op-eds and different things giving different opinions on this. And in fact, we don't really know which vaccine is the very best in the long term. But I do think at this point, if we have a vaccine we can give them the facts. We know the efficacy, we know roughly the safety profiles, and we can inform our patients and let them make their best informed decision. So far in Canada, no matter how you slice and dice it, every Canadian who's eligible will be able to be fully vaccinated by September. So depending on how old you are, what risk factor you're in, and what strategy your province is going with, that's really going to depend on how long an individual has to wait, depending and help them make their choice and decision.
Okay, thank you. You spoke about the 3 different vaccine platforms. Could you speak to the theoretical risk of these platforms in pregnancy and breastfeeding?
I think that's a really important point. So pregnancy and breastfeeding is something that there's 2 ways to look at it. One is, how safe are these in pregnancy? And are there any theoretical concerns? And then there's the other point of this argument, which is we always want to advocate for pregnant women and so that they also get access to the best available treatments. So this is the way that I perceive it. I can see no theoretical concerns at all with breastfeeding at all. I've heard no argument that you shouldn't use these vaccines in breastfeeding. And I personally, having seen a large amount of this data, feel perfectly comfortable giving these vaccines in breastfeeding women. Pregnancy is different. Again, I think it involves an informed choice. Generally, we at least know that there's a certain number of women who inadvertently get exposed to vaccines or other therapies. And then when their babies are born, we at least know from registries and things like that, that there are no safety issues. Very traditional vaccines like protein vaccines really have no safety issues at all in pregnancy. So I'm not at all worried about those. Messenger RNA, if I'm being very honest, is a brand new technology. It's completely new. And though most of us feel that now we've given it to several 100 million people and it looks like it's safe, at least in the short term, pregnant women need to be informed that at this point, we don't have good safety and pregnancy outcomes as far as, babies being born, etc. We do know women have some higher risk in getting COVID when they're pregnant. So they have to carefully themselves weigh their choices and do their own assessment of whether they wish to get vaccinated or wait till they deliver. It's a very hard choice. And I think all of us are concerned and well-meaning and really want to contribute as much data as we can to inform that choice as soon as possible. So that's why there's caution around it.
April, did you want to add anything to this?
No, nothing to add.
We'll move to vaccine effectiveness. I'm assuming it's the viewer is asking about how long is the vaccine considered to be effective for. I guess it's for the authorized vaccinations, if you can speak to that.
So that's an excellent question that we keep getting asked a lot. I think that when you look at this vaccine, it was authorized with 8 weeks of efficacy data. And that's only was able to be possible because the disease was so common and because of a lot of this expedited work on it. But usually when a vaccine is is authorized with a time, like when we say its efficacy is X%, it's generally longer just because the disease is less common and it takes longer to do a randomized controlled trial. But a general principle of vaccines is once you have an efficacy, if it wanes, it doesn't plummet. It doesn't drop off a cliff. It's not a precipitous drop. It's a very slow wane usually. So there's a lot of unknowns. We don't know how stable and how long the efficacy will be. We don't know if there will be changes in the virus that will make them work less because of it has a mutation that will make the vaccine less effective. And we don't know if we're going to need boosters every year, every 5 years, every 10 years. We're all in this journey together, and these questions are being asked and are really, really important. But I think one of the important concepts that if you look at other vaccines and how vaccines work, you don't just precipitatively drop off in efficacy, like you're protected one day and 2 days later you're not. That just doesn't happen. And also the longer the interval between doses, generally you get a much more targeted and better immune response. So those are just some generalities as we negotiate through how best to roll these things out.
Okay, thank you very much.
And I guess, sorry, Alexandra, I guess the other thing I would think about just looking through some of the questions on the chat is what we're starting to consider is we have kind of various different products available at different times. And there's some exciting studies going on internationally. I'm thinking about one in the UK where they're mixing different types of vaccines to try to hone in, exactly as Marina said, hone in on what the protective response is, which we currently don't know. So as science evolves and we get a better understanding of, okay, what is actually mediating protection, we'll be able to tune the immune response to be able to respond to changes in the virus and potentially offer Canadians a really good strategy for vaccination.
And actually, maybe because it's the same sort of themes, maybe I'll jump in here and talk about one of the questions that was previously asked to some of the other speakers was, what if you've already had COVID-19? Should you get vaccinated? How long should you wait? Do you need 2 doses? So we didn't know that at the beginning. In the randomized controlled trials, the people who had confirmed COVID were taken out of the trials, and they swabbed people's noses also to make sure that they didn't have active virus in their nose at the beginning of some of the trials. But it was looked at from a lens of, if I had COVID and I didn't know it, and there are people like that, not everyone got tested, and they were able to look at that by doing antibody tests, etc. So there are people who had COVID, who had positive antibody tests, who got the vaccine, and it was safe. But we're now finding out that if you already had COVID, giving a vaccine, 1 dose to those people, give them a big boost, and they get a really high immunity. As we've said before, we don't know the level of immunity that you need, and we don't know what is the correlative protection, but you get a really big boost. And if you give those same people another dose of vaccine, it never goes higher, and they get quite a sore red arm. So the National Advisory Committee for Immunization will be looking at this. We'll carefully weigh that. But some countries like France have said if you have had confirmed PCR positive COVID, you only should be getting 1 dose right now. And that gives us 2 things. It gives more vaccine available to people who never had COVID, but it also is probably better for the person who had COVID-19 to get 1 dose and maybe wait a bit. And that advice may change. You know, some people have put a 90-day parameter around that. It's not because we know 90 days is the right idea. or the right time. It's because we're learning as we go. And I think we have to do a lot more explaining to our patients and to our colleagues. We're learning as we go. I don't know the answer today. And if I know it 2 or 3 months from now, it's because new data came out, and we have to all be really willing to think differently and pivot and not say things like, hey, you said something different 8 weeks ago. We have to just keep changing and thinking and learning at, like, you know, the speed of COVID or the speed of light, which seem the same.
Thank you, Marina. Can you comment on the Canadian-based vaccine formulations? How different are they from Moderna or Pfizer? Can you speak on
You mean
that at all?
Medicago?
I'm not sure if the person means
Sure.
Medicago or the Providence from Manitoba. I'm not sure the answer to that question.
Okay.
I'm not sure what the question is. Sorry.
Well, maybe I can frame it a little bit. So there
Okay.
are some mRNA vaccines being developed in Canada, and the lipid nanoparticle technology, one of the early developers and early innovators is Canadian and based out of Vancouver. So there are different mRNA vaccines with that LNP technology developed in Canada and around the world. They are quite different from the virus-like particle technologies in the way that we've described the mRNA versus the protein. But these technologies are all coming to the fore and will all be reviewed by Health Canada when they're ready, when they've completed their phase 3, and also reviewed by NACI.
Thank you. Thank you. I think that's exactly what the attendee was after. I think we will wrap it up with a final question about the viral vector vaccines. Is it a live or dead virus? And can you give an example of such a vaccine other than
Yes.
the one for COVID-19?
So it is not a live vaccine. None of the vaccines that are currently being used for COVID-19 are what we would consider live viral or live vaccine. So it is not a live vaccine. And a previous example, there has been no widespread used viral vector vaccine before, but this is sort of the technology. Actually, Ebola vaccines have partly been used and are actually now, because we're having an outbreak of Ebola, because the world hasn't had enough infectious disease. No, it is my understanding that those are the ones that they're using, are rolling out now. So there's been some work on viral vector vaccines, but there's never been one that has been widely used in large populations. April, would you like to add to that?
Yeah, I guess I'd say they're not alive and they're not dead. They're kind of a new class where they're I think in previous versions of this, Marina, you and I used the castrated, but they really are. They're single round. You can't get sick from these vector vaccines, but they do have. They're live enough such that they're able to do what they need to do and get that spike protein, the DNA encoding the spike protein into your nucleus. And so that's really the vehicle for that. That's why they're called vector. And I know we're wrapping up, Alexandra, and I don't want to stress you out, but I do want to plug 2 other webinars that we're hosting. Next week, we're hosting a webinar on clinical guidance and vaccine administration. So some of those questions I saw here may be answered by that webinar, as well as we have a monthly emerging issues webinar series where some of the questions on allergies and anaphylaxis were answered in the previous webinar. And we have another one coming up in March that will discuss other things. So I'm sorry if I stepped on your toes, Alexandra.
Oh, no, that's okay.
I just want to be really clear that the viral vectors are non-replicating. Okay, so you cannot get sick, and they are not the same as, say, measles, mumps, rubella, or live polio, right? These are what we would usually consider in our vaccine buckets, non-live viral vaccines.
Yeah,
Okay.
that's important point to close this webinar on, for sure. So thank you very much to the 2 of you for this presentation. And I would like to thank all the speakers for presenting today. As well, I would like to thank Dr. Howard New for providing the opening remarks. Thank you all of you for attending, and we hope the information provided will help you in your clinical practice. Like April mentioned, NCCID will be hosting more Public Health Agency of Canada COVID-19 webinars for healthcare providers. For more information, check our website, nccid.ca. This same webinar will be presented in French on Friday, February 26th, and registration is still open at nccid.ca. And just to recap, next week, March 1st and 4th, we will have another Public Health Agency of Canada clinic planning webinar for healthcare providers, and you can get more information on this webinar at nccid.ca. The recording and slides from today's webinar will be available shortly after the webinar on our website. And please fill out our short evaluation survey when you leave the webinar. These surveys are important to our future planning. Thank you and have a good day.